Okay, we're going to get started. So I want to tell you that I know we started late. I'm going to take 15 minutes to continue after 10:30 till 10:45. And anyway, the rooms that we have for the next session, which are for the different specialty councils, are available to you for the whole day. I mean, you know. But anyway, let me just say, let me welcome you all for the NHMA, what we're calling the NHMA Medical Education Initiative session. Last year, we had our first Medical Education Initiative session with some of the same type of groups. And we're very proud to partner with the American Medical Association. I represent NHMA to the Health Equities Steering Committee. It's kind of a brain trust for Aletha Maybank. And we also have Dr. Judy Flores on the AMA Minority Affairs section that's part of the House of Delegates. We also have Ricardo Correa, who's been a co-chair of the IMG section at the AMA. Jesus De La Rosa, or Manny De La Rosa, Jesus Manuel De La Rosa has been a co-chair of the medical education section. I don't know if he still is. But anyway, and same with the ACGME. Dr. David Hayes Bautista, I don't think he's here. He's now representing NHMA on a special committee that was started to give awards to graduate medical education programs that are actually working in communities for social determinants of health. And we're our Hispanic Centers of Excellence. We are in the 5th year of an appropriations, and we've already met with our Congressional Hispanic Caucus members to increase the funding for the Hispanic Centers of Excellence, which are probably the closest thing we have to what the historically black colleges and universities have, which are institutions that have special programs for their communities. And it's not just recruitment and retention of the institution, it's actually helping the participants of the institution, the medical students that are not Hispanic, the faculty that are not Hispanic, learn about the Latinos in their community. So the Hispanic Centers of Excellence are very, very important to our organization. And honestly, when we started the Latino Medical Student Association way back when, it was with Jorge Girodi here at the University of Illinois, Chicago's Center of Excellence, and we also thought that the medical students should have a home with the Centers of Excellence, since we knew they would never really have staff. They're student clubs. So we want to tell you how important those are. And then we have one of the organizations here from, I'll just say from the Midwest, the Cleveland Clinic. Thank you very much for offering to come and share your stories too. But the purpose of this meeting is to hear what they do, but for them to recommend to us how we can have more nominations. We nominate our members every 2 weeks to opportunities that these organizations and others that come to us, whether it's media or program or speaking opportunities, being on advisory committees. We have nominations from the federal government all the time. The advisory committee for the whole Agency for Healthcare Research and Quality, Dr. Bob Valdez, who's one of my mentors, he wants a nominee from NHMA. I open it up. We would like anyone that has the qualified experience and knowledge to sit at the table. NIH has asked us for advisory committee members. FDA has asked us. CDC has asked us, especially for the vaccines and long COVID. And there's just so many opportunities. And you can even just be on grant review committees. And I'll just say, and I'll end here, that the grant reviews for those that are in academics, it's great to see your peer, the way they write their proposals, your peers. And that's the beauty of being on these advisory committees or grant review committees. So anyway, don't be afraid to when we send out nominations, we tend to get the same couple of people that want to be nominated to everything because they know how important it is that we can open the door for you. So that's what this session is about. How can all of you open your doors to the wealth of knowledge of the different people that are within NHMA? And they're students, residents, faculty, private practice doctors, as well as those that are not Hispanic that want to learn more and add value to what you do. Okay, so there's no disclosures here, and please fill out your information for the CME. And then I guess the only other thing I'm going to say is that we really value your evaluation at the end, because we want to build NHMA's medical education initiatives. And I'll just tell you one story. Really, is the reason we started this focus is because we got a grant. We were one of three, no, not three, I don't know how many, maybe 5, 10 organizations that got grants from the Office of Minority Health to develop innovative ways to diversify medical education. And we decided to do the workforce at the pipeline of college students, and we've reached over a couple thousand college students. We call it our NHMA College Health Scholars Program. And that program, we started before COVID, so we had live conferences in Southern California. We had 3 conferences a year, and we had it in San Antonio, Texas, and then at our conference in Washington, D.C. And what we did is half the people were given mentoring, half the students were not, and we showed statistical significance that the mentoring works. We know most of the people that we touched are first generation, not all Latino, mostly Latino, and about 90% want to go into medical school. Our career opportunities and our scholarships and our loans are all on our website for the College Health Scholars Program. And we did look at, and we had speakers, we have webinars, we'd like to build it. And we were actually looking at students who wanted to go into dentistry, nursing, science, public health, and medicine. And we want to continue that, but we want to continue also the mentoring and the sharing of information webinars at the different levels of medicine. And that's why we want to work with all these beautiful people groups. So the first speaker is Connie Calderón-Jensen, and she is an educational professional with 30 years experience of affecting students of color, especially English language learners and immigrant families. And Connie can tell us more about what she does in her slides, but she is with the University of California, San Francisco Latinx Center of Excellence. And NHMA wrote a letter of support for this one. We're actually on the advisory committee. I got to get a nominee for you to really connect, but I know Kathy Flores, who's one of our past chairwomen, is also on the advisory committee. And Alicia Fernandez, who's your director, is one of our fellows. So we are very much connected to the people that we have here, and we want to build NHMA through all of these efforts. Connie?
Oh my, I'm too tall. I don't think I've ever needed to say that. Okay.
Are you okay? You want me to move it?
I think I'm going to move it. That's fine.
Okay.
Okay.
Let me get my pen, sorry.
Great. Okay. So good morning, everybody. My name is Connie, buenos dias, Connie Calderón-Jensen. I'm the Associate Director for our Latinx Center of Excellence at UCSF. So I have no disclosures to report, except that this is my first conference. I'm very excited to be here and to see so many people interested in what we are doing for our pathway programs. The objective to my slides today is to help you understand the components of our pre-med summer program. What makes it special? The importance of community engagement in that program, what our scholars learn, and how our scholars feel about leadership and medical school by the time they're done. Are we actually making a difference? So who runs the Latinx Center of Excellence at UCSF? As Dr. Rios mentioned, Dr. Alicia Fernandez is our PI. She is nationally recognized for her work in diversifying the workforce, but internationally recognized for her work and expertise in language concordant healthcare and chronic disease within underserved communities. We work with 3 wonderful, powerful Latinas who are thinking about medical school, graduate school, and public health. So we're really lucky to have, even though it's a very small group of people, an all Latina group of people, which is even more fantastic. So the way we've structured our LCOE programs is to support people at different levels on the medical pathway. Our first program is called the Aspiring Physicians Program, and we have partnered with San Francisco State, Fresno State, and UC Merced. It's an intensive 6-week program where we prepare students to have the most competitive AMCAS. And we also do longitudinal advising and mentoring until they get into med school, and then they have to deal with me for the rest of their lives. For our medical students, we work with our rising second-year students. ALAS prepares our students to be successful on the wards. The majority of our Latino students at UCSF, not all, but the majority are first-generation medical students, many from low-income families. They don't know what they don't know when they get to the wards. And so this program works with them so that they understand how to ask questions, how to shine in a group of people, many of which don't look like them. The second program for our med students is our Prof Path program. This is a place for the students to learn how to do research in health disparities, and then also some career development focus. For our residents, we have Salud, and this provides mentoring activities, professional development activities with our senior faculty, but it also helps build community with our residents who are spread across the city. This is also one of the ways that we get residents to start thinking about academic medicine, which is also very important to us. And then finally, for our junior faculty, the School of Medicine has Watson Scholars, which are scholarships given so that junior faculty can start building their research portfolio. What the LCOE does with Fuego is to mentor these Watson Scholars so that they have a professional network of academic physicians, and also, building their knowledge about how to be a successful faculty member. It also gives us the opportunity to promote and retain our underrepresented faculty. So I'm going to talk mostly about our undergraduate programs. So the eligibility, by the way, these programs are all funded by a HRSA grant, and then we have some funds from the School of Medicine. So applicants have to have finished biology and chemistry, have a GPA of about a 3.3, have community and campus activities. HRSA also, because we're a Hispanic Center of Excellence, will provide stipends for only our Latino students in the programs, and so we let the students know up front. However, we do have some monies from our Office of Diversity and Outreach so that we can also have some African American students. The students actually sign a contract when they're selected, and what they're signing to is that they're going to participate full-time, which is a 6-hour day, for 6 weeks in the summer, that they will attend sessions 2 to 3 times a week. We have a hybrid program. One of the things we learned under the pandemic is that although there were lots of difficulties, that because everything was on Zoom, we were able to increase the amount of professionals that our students had access to. We didn't want to completely lose that, especially for our students in the Central Valley. So 2 to 3 times a week, they come to campus for in-person and hands-on activities. They must complete all the evaluations, very important for the HRSA people to know how our students are doing. And they also have faculty check-ins throughout the year. Now, our program started in 2019. We've had about 91 students have come through our program. And you'll see where they are currently. 12 of them have applied. Of those that have applied, 8 are in medical school at UC Davis, UCSF, and SJV Prime at UCSF. 3 are in the cycle now and still waiting to hear. 11 are currently applying, and 18 will be ready to apply next year. And one of the questions that I get when I put this slide up is why only 12 if you've had 91? For anybody who has worked with a first generation and low-income student that's coming from a state school, not a UC, there are incredible challenges that our students face. And so these are not the students who are going to be applying as soon as they graduate from college. Many of them have to take maybe a couple of gap years to either do a post-bac program or to get a little more experience. There's a lot of imposter syndrome that goes on, and so there's a lot of coaching. But of those that have applied, we have been very successful in getting them into medical school. So we did some research on our summer program, and we saw that we really have 3 pillars that go into the program to make it so that students have a very rich and meaningful experience. I'm not going to go through each and every part of these pillars because I want to make sure we have enough time for everybody, but the first pillar is the medical school preparation. We do a lot of career exploration, medical school readiness, which is when they work with me to actually go through the whole AMCAS process, and letting them know that getting to medical school is different for everybody, that they do not have to be like their friends who are applying, that it is a very personal experience. We also do an introduction to MCAT. Most of our students, like I said, aren't going to take the MCAT until maybe 2 or 3 years after they graduate. So having them experience what it's like and being taught strategy and best practices by our medical students really goes a long way. The second is personal and professional development. Our students have incredibly rich narratives. Many of them see it as a negative. They don't see it with an asset-based lens. They don't understand the importance of their grit and how to talk about it. We really go into depth about that. We talk about the importance of mentorship. We also talk about social cultural barriers, so imposter syndrome, unconscious bias, the importance of leadership and leadership development so that by the end of 6 weeks, they understand that they are leaders in their communities. And then the third is health policy and advocacy. You've noticed that we're not doing any science teaching per se in our program. The one thing we do teach is public health and health policy. I don't know how many of you are aware, but for many of our students that are pre-med or biochemistry, students, they have no idea about public health, and they have never heard anybody speak about public health. And so we bring in people like Dr. Sandra Hernandez, who will talk to them about, yes, being a physician, but why she chose to go into the realm of public health. Y se les prende el foco, right? They're like, oh my gosh, I had no idea, and they start thinking about the MPH. Policy advocacy, how they, as students, can help advocate for policies that have a great impact on their community. And we do this by exposing them to local community-based organizations, and they do research on creating fact sheets that they can use with the legislature and with other fundraising opportunities. So this is an example of one of the fact sheets that the students created, and this was in 2020, so COVID was very, very on the minds of everybody. And this is just a little bit about how we choose the CBOs and what the students gain from creating these fact sheets that then the CBOs actually use for their daily work. Touch points, again, there's, our students need a lot of cariño, and so we provide that. We provide a home for them. I make sure that they get all of those the wonderful workshops from the AAMC, different scholarships and other summer programs, and they are also very involved with the mentorship programs from our LMSA. Best practices, we have to make sure that we are evaluating our programs, that we are amplifying the ideas that they want to see. We do provide a stipend. However, we did learn that giving the stipend up front creates less engagement at the 5th and 6th week, so we divided it up, and we let them know that if they don't adhere to the contract that they signed, that their second disbursement might be a little less. I do want to let you know that this research was published in Medical Education Online, so there's a lot of in-depth information about how we do our work and why we're doing it the way we're doing it. And this is what our app program makes students feel at the end of 6 weeks. So you'll notice that there's lots of very powerful words here. And for students, like I said, who, for example, at San Francisco State have no pre-med and no pre-health advisor, these are very powerful ways for them to be feeling. So I will cede the floor to my next panelist.
Very good. So we are going to have questions at the end, the microphone here, and be thinking about how you as individuals can help NHMA amplify on what we just heard. I've already written down a million things we could do. And everybody here has ideas that we can work with. The next presentation is from, Joaquin Baca. He is the Director of Diversity of Equity, a Director of Equity, Diversity, Belonging for Medical Education at the AMA. He served dually as the New Mexico Department of Health Deputy Director of the Office of Policy and Accountability and Director of the Office of Health Equity. So he has a long time commitment to public health, and we're very happy to have a Latino leader within the AMA. We need more Latino leaders within our stakeholder institutions that we work with, but he has facilitated cultural competency courses for medical students and has a long history of working on diversity issues. Joaquin?
Buenos dias, and I like to use, there's a poem that was dear to me, so I like to say, Yo soy Joaquin. That's one of my favorite poems because of that. It's not as common of a name in most places, so it's good to be able to say it proudly. So I'm going to go forward and just talk a little bit, and I'll start off, especially because Dr. Rios mentioned about the House of Delegates, and as a fellow professional membership organization, and one that is primarily focused on advocacy for physicians in many different ways. One of the ways that we advocate is, of course, on larger issues with the courts, but also with other federal policies and other places. So we encourage your membership as much as possible to change these policies and to move these policies forward. And I'll make that more clear as I move through some of the slides and see how important it is that we work together in really examining and thinking about these policies and how we move them forward to really make a big difference, especially around health equity and that motion. So I'll briefly discuss and try and go through this very quickly about the Supreme Court case that's up right now around affirmative action. And this is, it's going to have huge implications, I think, in many realms, and it may be even more substantial in how it shows up in the states, just as what happened with the Dobbs case with reproductive justice, and how that's kind of demonstrated itself in the states as well. And so we're tracking some of that. We're also looking at how to look, at the root causes of some of these things that we're talking about. Imposter syndrome is an example, but also where people get the sense of where they belong and don't belong. It comes a lot from just structural oppression and some of the policies that have been put in place that deliberately put people in a place of disadvantage, and who gets advantage from that. So flipping the narrative a little bit and thinking about how things have been created to give advantage to particular people and not to others, and at the same time disadvantaging those to make sure that that's preserved. So that's also looking at how health equity might be and was fundamentally developed to really focus on social justice. And I'm going to parallel that to affirmative action, which I think is also originally was focused on addressing social justice and how that has changed. It's evolved, and some of the historical kind of context around that. So I don't have any disclosures, so I'll just move forward. But so the American Medical Association produced a strategic plan on health equity a couple of years ago, and I helped to put together different timelines of the structural racism that exists across time in different populations. And so this one is one that's focused on Latino structural racism. And you could see the different things that have been done through federal policy, specifically in this case, these are mostly federal policy issues that have been put in place, to really make sure that Latino did not have the advantages, or make sure they were disadvantaged in many ways, I'm going to say, through particular things, including theft of land, including deportation, even though you're a citizen, including what happened just with the family separation policy a couple of years ago. These are all things that contribute to how structures are disadvantaging particular populations very specifically. And there's a long history of it. You can learn more if you want in the strategic plan. There's a little more history in all this. I'm not going to get into detail, but I just want to point it out that it's not a very simple kind of process of, and I'll also say that these are things that go across many populations. These are going parallel to things that are happening with African American, Black people, also with Native American, American Indian peoples, with people with disabilities, people from the gender issue, with gender-based discrimination and gender-based kind of policies that have hurt not only women, but also people that are non-binary and other ways of gender expression. So this is common right now. So the big case is around Students for Fair Admissions Incorporated and versus Harvard and the University of North Carolina. And I want to point out, it was a race-conscious admissions process is unfair to white and Asian students is the terminology they use. And it's a very interesting framing because in many ways, the original framing was that things were unfair to everyone else but white students. And so I think that was the whole point behind affirmative action. So I think it's interesting how it's kind of been reversed. And I'll show progressively that the policies and the legal precedents have been set, have been moving in this direction over many, many years. So AMA did sign on with AAMC for an amicus brief to really say what we saw was not appropriate about the entire lawsuit, but also about what the damage it could really create if there is a negative decision on this. So, and it is very strongly, the whole case is strongly based on what happened with other cases with Baca, Grutter, and Fisher. And I'll talk a little bit about those three. Grutter, Fisher, and Baca were responding to challenges to affirmative action. I'll go a little bit more in the history of the affirmative action later, but they were put in place affirmative action was put in place to address blatant and rampant discriminatory practices. And so I think, and when affirmative action was first instituted, and I will make a tie between affirmative action and diversity, I promise, and between that and these other things, but it was originally focused on correcting the past wrongs, and in particular around, and I'm going to get into it, slavery, and the 14th Amendment was put in place to really rectify the wrongs and the subordination that was occurring because people thought, even though the slaves were free, that they still should be less than or subordinate to others. And so these things were put in place to really correct that. And so I think that that's at the foundation, and that's where, at its origin, it was really focused on social justice, on correcting those wrongs. But as time went on, affirmative action, because of these Supreme Court cases, devolved. It was changed, and primarily because of the enforcement that didn't happen through the 80s. There were political things that came into place that made it so that the president at the time didn't feel like it was appropriate to really pursue a lot of the cases that were being put forward through these offices of civil rights, and so that led to a huge workforce that had been hired to enforce these cases in different places, to have to pivot into a different role. And what they pivoted into was something they called diversity. And so that's where the diversity, equity, inclusion kind of started. It was out of the fact that we didn't really want to put the time into addressing social justice anymore, and in particular through a non-discrimination framework, which I'll get into too, or I could, it would take me a while, but that framework really pushed it into even less work, less focus on, well, we'll just make sure that we're trying to increase the diversity of representation in the workplace in many ways, in many places, or in our case, in the workforce of physicians. So here is another timeline on the different kinds of things on the evolution of diversity, equity, inclusion over time from some of the Supreme Court cases that really formulated, moving from what was called anti-subordination to then now what is now non-discrimination frameworks. So non-discrimination meaning that the burden of proof is put onto the individual making the accusation, that feels like they're getting discriminated against, and all the organization or the person that's getting accused has to do is that they have done their fair work to avoid that discriminatory practice. And so it doesn't really, and you hear this all the time too, even in the current discrimination cases, how much work it is for the person who is getting discriminated against to prove that they are experiencing discrimination versus it being about protecting people in their places and really putting the burden on the organization, institution to make sure that it is a welcoming and a place where everybody can feel like they belong environment. And so I think, so now a lot of DEI efforts really focus on maintaining that kind of appearance of we're doing our best through these diversity initiatives to avoid discrimination. So we're just trying to build a place where we know we can demonstrate if somebody sues us that we've done our fair share of work to avoid that lawsuit. And so instead of it being about, well, we want to make sure we're protecting every single person here and they feel good about being here. So again, the three cases on this that are really significant are the 14th Amendment, Fisher, the Baca, and Gratzen and Grutter, and now we're at this point. So, and the particular attack on this current case is against Grutter and primarily Grutter, and that's what's going on right now. So, oops, sorry. So in Grutter, and I'll go into this, that was where originally the Supreme Court ruled that racial diversity is valid as a goal in higher education, but it had to be done very carefully. And AAMC responded with that by creating the holistic review process. And so this is one of the places. And that was only in 2003, and the Justice O'Connor at the time said, within 25 years, we probably wouldn't even need this anymore. So we're almost at that point. And so you can see that this current Supreme Court is kind of at the heels of that premonition of Justice O'Connor saying that we would need to depend on, which, you know, in terms of the numbers, we really haven't changed much. So from that case, we really, it is even more important that we double down in terms of how we change things. I feel like it should be done from a different stance, not from affirmative action, because, or we need to really go back to the roots of affirmative action and fix it. But so short-term, long-term kinds of effects of a negative ruling here, and then I'm going to go more quickly because I'm going to make sure we have time for everyone. But this is kind of the framework of how diversity evolved. It was really based originally on affirmative action, moving to, well, we're going to just value the differences of everybody in the organization, and then moving to how do we make sure that everybody in the organization is comfortable with each other. And so there are strategies that can be used, and that's called the managing diversity strategy, or diversity management strategy. And that's kind of the direction that diversity has gone over the years. And you can see that currently we're in a phase of diversity management that is more focused on how we fit into the global economy. But still on that same, it's more of a business orientation than it is about social justice. Where on the other side, especially within medicine, medicine has always been focused in many ways on social justice, and I think that when there was starting to be more and more of a focus on the health disparities, that there were differences in health outcomes, and people saw that how bad that was. They wanted to start working on that, started looking at kind of why that might have been, looking at some of the social determinants of health as a cause potentially, and now moving more into the structural drivers and understanding the policies at the federal level, like I was pointing out, and all these things that have created depression and have created the situations, created the inequity, not just this disparity, but there is deliberate practices that have created these differences. And so that we call them now health inequities, not health disparities anymore, and focusing on these social drivers and how we have to change those structures in order to actually make a difference in closing the gap of these disparities. That's leading more towards health justice. And focusing more on how we create equitable structures to create that health justice and address it again. That's at the root of, in medicine, public health, health equity as a model. And I think that's the direction the whole field tends to be going. And so kind of overlapping the two models just to see how those are developing in parallel. But as I did a literature review in the last year, I did 252 articles, just did a keyword search on diversity in medical education, looking at where people are right now in the field and how they're thinking about it. The primary rationale for doing this work were health equity based. And so just to argue again that as a field, and not just me saying this, but as a field, the people writing about diversity are also saying that the purpose for doing that should be around health equity. And so it does seem like it's a natural pivot point, a natural place that the field is already moving, and something that we can build on. And I think in terms of the partnerships that we're talking about, that we can be focused on how to address health equity as our foundation. Maybe look at, and the way I think of it, diversity should be an outcome of health equity or equitable strategies. So the more that we fix the structures, the better we'll have the diverse state that we want to be in. And so that's where I hope we can get to. I think, like was mentioned, the Center for Health Equity did do the strategic plan around health equity. Lots of thoughts in there about how to do this work and how to move things forward. And I'll just point people to that. There's it's on the AMA website, and we have a lot of great things. So thank you so much.
Thank you. Again, write down all your ideas of how we can help with all of these great leaders. Our next leader is Dr. Pilar Ortega from Chicago. She's the Vice President, Diversity, Equity, and Inclusion at the Accreditation Council for Graduate Medical Education. Accreditation is very important as a driver of all our health professions, and we need to understand from Pilar, who's brand new to the organization, how the Latino picture in graduate medical education can be influenced by the levers of ACGME and how we can be part of the ACGME. Her efforts are to improve retention and well-being for diverse resident and fellows physicians, address harassment, discrimination, and other forms of mistreatment in graduate medical education learning environment, and disseminate information, again, on this diversity, equity, and inclusion activities to the GME community. So Dr. Ortega, thank you very much. And I know she's got let me just say, she's got a strong history with medical Spanish, and I hope that that becomes part of the ACGME too. Thank you.
Muchas gracias, doctora Rios. ¿A alguien más le duelen los pies de anoche? It's a good feeling, though. I think for me, it's particularly an honor to be here with you all today. This is my 20th year coming to the NHMA conference, Dr. Rios, because I've been coming since I was a medical student, since my first year in medical school. So it is extremely special for me to be here in front of you today in, as Dr. Rios said, a brand new role, and to witness what I think happens at this conference every year, which is that individuals come seeking mentorship, individuals come offering mentorship to others, individuals have been helping each other with mobility that we saw yesterday several times throughout the event, older people and younger people together, men, women, people who look differently, who sound different, different languages being spoken. All of this happens in an environment where we feel we can build community, and I think that's the real value that I see every year coming back to NHMA conference, and I think where part of that education that we're talking about today actually happens, because it really fuels us to do the work that we are trying to do every day in our day jobs. Recently, I joined the Accreditation Council for Graduate Medical Education, and I'm going to share with you a little bit about what we do and my role in particular. So first, I'm going to quickly tell you about the ACGME's vision of diversity, equity, and inclusion, and Latino health and how Latino health falls into that. And in particular, I want to talk about some of those skills and attributes that we have as Latinos in medicine. And by the way, I'm the first Latina in a senior leadership role at ACGME ever. So it is particularly important for us to have a seat at that table, I think, to make some of these skills evident when maybe they haven't really been talked about. And I think one of those is language, and as Dr. Rios mentioned, something that has been the core of my own academic career. And then I want to talk about those opportunities that we have to partner and to do better. So the ACGME, almost 4 years ago, did a few things to really integrate the concepts of diversity, equity, and inclusion throughout the organization. One of the things was to initiate a department of diversity, equity, and inclusion, but importantly, recognize that diversity, equity, and inclusion is not the sole responsibility of that department. So part of our mission statement now reflects that we are aiming for improvement of population health. That is only possible if we actually substantively and meaningfully make a difference in diversity, equity, and inclusion. So we recognize that it is part of our mission and values as an organization. And as such, we have also modified the program requirements, which for those of you who are maybe in medical school or other aspects of your training or in other fields, the ACGME accredits more than 12,000, it's the sole accreditor for the more than 12,000 residency and fellowship programs in the United States. So this is a very important way that we have the capacity to influence what are requirements of programs and sponsoring institutions, and one of those requirements is around diversity, equity, and inclusion, and I'll share a little bit more about that in a moment. And importantly, we need accountability for that. So it's not just a matter of we now have this requirement or recommendation. It is a requirement, and there is going to be accountability associated with it, but we also recognize that we need to give people the tools to actually do this in a meaningful way and not just check the box. And so that has been the focus of our office. So to share a bit about how we're viewing diversity, equity, and inclusion overall, each of these are separate concepts. So they often get conflated together as DEI, but it's important to sort of parse out what we're doing. And so first of all, it's critical that we recognize that health disparities is a deficiency of healthcare quality, period. Not just healthcare quality for some, healthcare quality, period. Secondly, health equity is how we achieve the elimination of those healthcare disparities. Increasing workforce diversity is a means to achieve health equity. And as has already been mentioned, inclusion and belonging are essential pieces because it's not enough to diversify the workforce if the place where they're going is not providing an environment in which these individuals can thrive. So I always go back to these two principles, which is why does it matter if we diversify the physician workforce? And I know I'm preaching to the choir here, but I also want to give you the language to discuss this with others. So I think the two things are, number one, population health, as was already mentioned. We know, and I'll show you a little bit of data with regards to language just to go into something that isn't talked about a lot, but racial, cultural, and language concordance improve quality of care and improves access to care. We know that. We also know that diversity in teams drives excellence. We know this from business literature, and it actually drives economic success and productivity in companies. So this is not new. This data has shown this across multiple disciplines, and it also drives well-being and innovation. So these are things that we want in medical education, we want in healthcare, and diversity is how we achieve it. So this is the common program requirement that I was referencing before. So we require, ACGME requires that all programs, in order to be accredited, must engage in practices that focus on mission-driven, ongoing, systematic recruitment and retention of a diverse workforce, including residents, faculty, and staff. Okay, so this is the primary requirement that really drives diversity, equity, and inclusion expectations across programs in the United States. And I want to mention that while most of our data collection, and I think data is a key part of how we can and need to partner, our data collection has primarily focused on race and ethnicity, also gender, but we're actually only starting the conversation around sexual orientation, gender identity, and how to track that appropriately across stakeholders. So the Association of American Medical Colleges, the AMA, and ACGME are part of a collaborative effort to align our data. But it takes an amazingly long amount of time for these people from all of these organizations to agree upon how to collect and track this data. But these are not the only things we want to look at. And so I want to share a little bit about our unique skills as Latinos, and in particular, I'm going to talk about language and how that adds to a benefit to population health and an impact on health disparities. So first of all, this is just some references in case you need to cite them at some point. We know that historically marginalized clinicians are more likely to practice in underserved areas, right? So it's really important that we really make that point super clear, because if we want to improve population health, we need to get the doctors to those places where there is a deficit in physicians. And who is willing to do that? Usually the people that come from those communities. And in fact, we know from data that the odds are high that a Black, Hispanic, or Asian physician will disproportionately see a patient of their same race, ethnicity, or language. Okay, so you can actually see the odds ratio of the physicians taking care of patients with whom they are concordant, either racially, culturally, or linguistically. At the same time, we can't only rely on concordance right now, because the percentage of physicians that are actually being trained, of marginalized physicians that are being trained, hasn't basically not changed for the past 15 years. So yes, we need to change and diversify the workforce, but we also have to train everybody in cultural humility. This is the data that I was referring to that's from the paper that was previously referenced, where you can see, and I'll just point out that for Latinos, if you are a Hispanic patient, it is 19 times more likely that you are taken care of by a Hispanic physician. If you are a patient that reports a non-English language preference, it is almost 18 times more likely that you will be taken care of by a Hispanic physician, because most of those patients speak Spanish, right? So this is a paper that shows that language concordant care, when the doctor and the patient, or the clinician and the patient, speak the same language, the outcomes are better. So this is a systematic review of a lot of papers that altogether show that outcomes are better when there is language concordance. Additionally, when you take a look at the language skills that we come in with when we apply for residency, just look at the number that I highlighted there in the red circle, which is for those residency applicants who identified as Latino of any nationality, 91.4% reported having at least advanced level skills in a language, which almost for all of them was Spanish. 91%. So this is self-report. This is imperfect because it is self-report. But this is a huge skill set that Latino resident physicians are bringing out with them where they train. And we are pretty much not making any decisions related to where people are matching based on language right now. There's in fact a paper showing that there is a complete discordance between where people are matching and the language skills they report relative to the languages spoken in those local populations. So I think that is a huge opportunity there. We see similar trends in practicing physicians. So recently we used data from the AMA master file and from a survey done by AAMC to look at the languages reported by practicing physicians today. And although we see that the most common language reported by physicians is Spanish, 35.5%. You can see the rest of the top 10 languages shown there reported by physicians. It doesn't align with the languages of patients in where they're practicing, and the frequency of use is really interesting because you can see that Spanish, again, is the one that is used the most frequently with patients, and yet also the one in which there is the most significant deficit of Spanish-speaking physicians because of the need in the population. And so interestingly, some of the other languages that are also reported by physicians that are reported as being used really frequently are not some of the ones that are more common among physicians. For example, you can see Vietnamese is reported by more than 40% of the physicians who speak it, that they actually use it with patients, but this is not a language that many physicians are reporting. So again, there's a discrepancy not only in Spanish, but in a number of languages as well. And I think part of this goes back to the fact that we really don't value language. In our society, we consider multilingualism a deficit rather than, in fact, we call limited English proficiency limited from a deficit-focused mindset instead of an asset-focused mindset. So we need to change that. We need to stop saying the term language barriers. Language is an opportunity to communicate. It's not a barrier. It's systems that have barriers that prevent our patients from accessing care and from us to be able to provide the best care that we can as physicians. So we definitely need to make a change in that. There is ongoing research and new options for certification of language skills that we have worked on primarily in the medical student setting, but we are indeed bringing that to graduate medical education next. So if anybody is interested in that, in those opportunities in particular, I'll be happy to address that later. And then, as I mentioned before, I think the things we need to all work on together are two things. One, we need to work on increasing and supporting the physician workforce diversity, of course, inclusion and belonging, and we need to train all physicians, regardless of their backgrounds, to be able to take care of all patients. And so at ACGME, we have a number of opportunities available that are freely available to all of you. So if you scan the QR code, you can go to our Learn at ACGME site, where there are many video modules available that you can take back to your hospitals and training programs that people can actually take in courses that are quick to watch the videos and get CME credits for. on things like how do I do holistic review of applications, how do I create a trauma-informed conversations in my department, how do I institute a bias reporting system in which trainees can feel comfortable raising their complaints and concerns. So this is free information. You do have to sign up as a user, but it's free. And we also want to recognize people that are doing this correctly. So I invite you to check out what we have to offer, and I'll pause there. Thank you so much.
Thank you. Okay, keep those ideas generating. Next, Dr. Monica Vela, Associate Professor of Medicine and the Associate Dean for Multicultural Affairs at the University of Chicago Pritzker School of Medicine. She's since joining the university in 1997, she has established herself as a leader in scholarship and education related to healthcare disparities and diversity in medicine. Dr. Vela.
Gracias, Doctora Rios. I am actually now at the University of Illinois. I moved about 18 months ago, and I moved for a very specific reason, and that was to head up the University of Illinois Hispanic Center of Excellence. Thank you.
Sorry about that.
No, no, not at all. I was at the University of Chicago for 27 years. It was not easy to leave my patients, my beloved friends and colleagues, my beautiful students, but I did it for a passion. This is my passion. I have no financial disclosures. I'm going to very quickly move through my slides because I think it's going to be really critical for us to get into discussion. But I do want to tell you a little bit about the state of Illinois. Our Hispanic Center of Excellence is predominantly funded through the state. So we use taxpayer money to do what we are doing. And that's key. It's key because Illinois is in great need. Illinois has 245 health professions shortage areas for primary care. 7 of the 12 predominantly Hispanic neighborhoods in Chicago are designated HPSAs. Hispanics continue to have the highest rates of uninsurance, and we are 50% less likely to receive mental health treatment compared to non-Hispanic white people. The pandemic made this much worse, and it made it much worse amongst our young people. When I interview students for medical school, I ask them, what did the pandemic do for you? Right? Invariably, our white applicants say, oh my gosh, I know there was a lot of suffering going on, but I went home and stayed with my parents. I reconnected. I enjoyed my family. It was, a time of great growth for me with my family. My Hispanic students don't answer that same way. They tell us about the loss that they experienced, whether it was that their parents lost their jobs, or it is that they lost a parent or a grandparent. Big losses. They took a hit. Their education took a hit. Our Hispanic neighborhoods do not have Wi-Fi readily available. And so when education shifted, our Hispanic students lost greatly, right? This is a disparity. The education gap widened for our Hispanic students. And so we feel that we need to do something about it. We also need to do something about it because our Hispanic population is only growing and aging in the United States. We are in great need of physicians who speak our language, whether that's Spanish or some other Latin American native language. We are in great need of Hispanic physicians who understand our life experiences and can speak to growing in poverty, losing family members because of disparate health care, losing family members and wealth during the pandemic, right? And this will not be the last pandemic, and so we need to shore up our resources and be prepared. We know that we need to start early, right? We lose a lot of students way too early. So we need to be alongside them as they navigate the American educational experience. And so the mission of the Hispanic Center of Excellence is to improve the health and wellness of Latinx communities in Illinois and across the United States. Our team actually delivers programs that increase the number of outstanding, and I will never remove that word, Latino and Hispanic applicants pursuing health careers across the healthcare system. Our programs span the continuum of health education and promote health practitioners who capably deliver both language concordant and culturally responsive care to historically underserved communities. How do we do that? I want to make sure to provide appropriate props to Dr. Jorge Girotti, to Dr. Elena Rios, who helped with the founding of the Hispanic Center of Excellence back in 1971.
No, I was in high school in 70.
And also make this point. But you've supported the Hispanic Center of Excellence a great deal in your tenure at the NHMA. Yes. Make this point. There were 3 times as many centers of excellence in the 1970s funded by HRSA grants than there are now. What happened? Right? In 2014, the University of Illinois earned the designation of a Hispanic serving institution, and this is really important because there are only 5 Hispanic serving institutions in the continental U.S. that have a medical college on their campus. This is both an opportunity, but also a responsibility to do the work that we are doing, and it should be better supported by both the state as well as HRSA and other entities as well. UIC is the only college of medicine that is accredited to have graduated over 200 Hispanic students in a 10-year time period. That doesn't sound like an awful lot, and it will not meet the needs that we have. And in fact, if we took the number of Hispanic students we are graduating today and doubled them over the next 100 years, we still would not meet the need that we will have in the next 100 years. So our Pathways programs span the continuum. We start at the pre-college level with Medicina Academy, go through to the undergraduate level, and I'll describe some of these programs, but not in great detail because I want to get to the amazing outcomes. And then we support students in medical school as well with a research program. All along the way, we have a parents program that I'm excited to tell you about as well. So Medicina Academy recruits about 30 students per year in the 8th grade. We do not cherry pick these students, so we don't go to schools and say, give us your brightest and your best. We say, give us your most motivated. Tell us who wants to be in our program. We recruit 30. Our College of Medicine students serve as mentors, and that's really key, super important, and we can't thank them enough. We help them with their literacy, their critical thinking skills, their writing, financial literacy, and we sit down and help them with their college applications. Interview skills as well. This is our 7th year in a row that 100% have been accepted to college. And you see the colleges listed there, but we don't stop there. We teach them how to negotiate for great financial aid packages because we don't want them to graduate from college with just skills. We don't want them to graduate from college having such a degree of debt that they are unable to pursue their dreams, that they cannot contribute to their families, that they feel so bogged down that they start to wonder why they went to college. That's not the goal here, right? The goal is to get them there and through and thriving and contributing as well. Our Medicina Scholars Program is our undergraduate program. Again, we recruit about 35 UIC pre-medical students. So they declare their pre-medical and we go after them with a structured 3-year curriculum. We meet with them regularly, whether they need to or not, whether they realize they need us or not. 99% are Hispanic, 81% are first generation, and get this number, 90% are bilingual. And we make sure to celebrate the bilingualism, right? We bring it to the table constantly and say, this is an asset. Do not let it go. Do not stop speaking Spanish, no matter how surrounded you are by only English speakers, right? This is a gift. Our completion rates, despite not providing a stipend, let me say that again. These students come to the table for 3 years without a stipend available to them, is 95%, over 95%. And then this is the real take-home message. If we look at students, and again, we're not cherry-picking the top students, four-year graduation rates for UIC Hispanic students who are not enrolled in our program is 30%. That's not to say they leave not having graduated. That's to say sometimes it takes them 5 years or 6 years or 7 years, because sometimes they have to pause and go home and work to be able to pay for the next semester, right? Our completion rates in 4 years, our students graduate at a rate of 75%. What does that mean? That means that these students do not have a deficit. There's no reason they should be graduating at 30% other than economic reasons. It means they just need support, right? They need some love. They need to be told, you can do this. You will do this. We are going to be here with you throughout the way. 7 Medicina scholars were admitted to medical school in 2021, 2 to the University of Illinois. 1 was accepted to a veterinary school, 1 to the College of Pharmacy, 2 to the nursing school at UIC, another to a different nursing school. 11 are applying in this cycle. And that's a fabulous number when you look across to other medical schools who don't have 11 Latino students in their entire cadre. This year, in 2022, this past year, 33 Latinx students graduated from UIC, 94% matched into residency, 47% into primary care, 38% matched into Illinois residency programs. So I say to you, the state, it's getting its money's worth when it supports the health center. Our Padres Leadership Institute is very important because our parents most often do not have even a high school graduation, right? And most of them did not get their education in the United States, and so they don't know how to navigate the American medical education system, which is incredibly difficult to navigate even for people who grew up in this country, right? And especially to navigate without acquiring a significant amount of debt. So what do we provide for the parents? We teach them about the American educational system. We help them with their own literacy and their health literacy. We give them hands-on CPR training. Because why? Because more Hispanics die in their communities from cardiovascular events than any other race or ethnicity, because CPR is not available to them. When you call the American Red Cross and ask for a bilingual trainer, good luck to you. And so this year we decided to go to the next level and train our parents to be trainers. And we've written a grant to that effect. We also have connected our parents, recognizing how much money makes a difference, to programs where they can actually acquire new positions. So Northwestern is coming after us right now because they've learned about our Leadership Institute, and they are looking to hire promoteras, right? We are going to funnel them that way for paid work, doing what we have trained our parents to do. And that helps everybody. We need your help. We need your help in making sure that these Hispanic centers of excellence do not go away. We need your help making sure they stay well-funded and that people are contributing to them. Sorry, I'll stop there.
That's okay, thank you. I said this earlier, and just to add a comment right here, the NHMA is very much involved with the Congressional Hispanic Caucus, the Congressional Black Caucus, and the Congressional Asian Caucus on the reauthorization this year of all Title VII programs, especially those programs like the HCOP, the Centers of Excellence. And I don't know if you know this, but President Biden has introduced a brand new program, $28 million, for training providers in underserved areas, not disadvantaged, but in underserved, that come from underserved areas, that are in underserved areas. And I think that the writing's on the wall that the Supreme Court, everybody expects to get rid of racial admissions. We're calling it racial neutral admissions. But what's going to happen is there will be proxies for race that will be developed. And California in 1996 and Texas in 96 had to change their admissions policies to higher education. We went through this already. And what we did is said, well, I was on the admissions committee for UCLA Medical School. Well, instead of looking at what race you are or ethnicity, we have to look at your cultural background, the barriers you had when you grew up, your parents' educational attainment, your parents' occupations. And so all of these social determinant kind of things were looked at as proxies to find students that were underserved or underrepresented. And I think that's what we're all talking about and what's going to be the future. So Monica, yes, we're very much engaged in advocacy and whatever we can do to help. With one of our congressional briefings this year, we need to focus on all of this. Love to have some of your, some of you speak on this then in Congress. Our next speaker is Dr. Eric Yudelevich. Born and raised in Mexico City, he completed medical school at the Anahuac University in Mexico City in 2011, internal medicine residency at Mount Sinai and St. Luke's and Roosevelt Hospitals in New York City, along with the chief resident year. And he is now working at the Cleveland Clinic, doing inpatient hospital services, outpatient primary care, and he directs the longitudinal clinic program at the Cleveland Clinic Lerner College of Medicine. Dr. Eric.
Thank you. Buenos dias, everyone. Happy to be here. And I want to say, listening to everyone that preceded me today, that what I was thinking for my section, and I hope that this will work that way, is to try to, kind of bring a perspective of what individually we can do in our institutions, particularly, not only, but particularly if you're involved in an academic institution. What are the things that we can do locally without necessarily being part of a larger kind of any of the institutions we already heard about, or without grant support? And I think there's a lot of things we can do, so hopefully we'll get through most of them. A couple of ideas and maybe more steer a conversation for things we can all do at our individual sites. Certainly no disclosures, and the next slide is kind of obvious to everyone here, but just keep that number in mind. 103 million will be the projected Hispanic population by 2050. That's a huge number. It's almost, I think the population in Mexico is 120 million. So just to put it in perspective, it's a significant number. And I want to talk about specifically the need for the pipeline. I think, the need is very obvious. We've heard it throughout all the presentations today, throughout all of the presentations in this meeting in general. But one thing I want to share is the concept of advocacy. I think the concept of advocacy was one that kind of scared me, and I felt it was a little intimidating when I heard advocating, right? Because I'm not part of, I'm not working at, I'm working individually. I have my clinic. Yes, I work with the med school, but how can I do really advocacy? I tended to think more of the legislature side. There was a lecture once by a VA doc in Cleveland who does a lot of transgender care, who was talking about advocacy. And she was talking about how, for her, advocacy was giving lectures on the topic and educating people on the topic. And it really changed my approach to advocacy and kind of made it like, okay, I can see the value in that, and I can see how that can be expanded. And the approach that I hope to do today is really that small but very effective level of advocacy we can all make wherever we are. I think it's very clear that if we have more leadership, if we have faculty that are like us, we will be attracted to going there. As a resident, in New York, I remember like one of the first people I heard was like Georgina Osorio, who is actually a member of NHMA, and she's a fantastic physician, ID doctor, and an individual. And although my last name, if someone hears it, would not necessarily make you think, oh, Latino or Hispanic, hers did, and I remember reaching out to her right away and saying how nice it was to know that. And then she introduced me to all these different faculty, and I think that's something that we try to promote also to people who come to interview, because we feel like the more they see us there, the more they want to come. So if we talk about the pipeline, and I kind of want to use this to guide us through. So we're talking about how to get more Hispanic med education leaders, or leaders in general, like in any aspect. But for getting there, there's a few steps before that. We need first to have a Hispanic physician, and we already heard of all the challenges to get to this point. For that, we need researchers, fellows, or residents. And for that, we need, first of all, a student. We're talking IMGs or US grads. But if we don't start there, we'll never really get to the numbers. And talking a little bit earlier, we're discussing how that percentage hasn't budged. The percentage of Hispanic or people applying hasn't really increased. And that's a problem because the population is increasing, so that the actual percentages will start to go down when we need it the most. We have heard, if we go on the top part, we have heard of so many, and I put here a few of the examples, and I'm going to have a few more on the next slides, but actually UCSF, all the different programs we already heard about today. I was trying to keep track of all the lists, like the AP program that was presented, ALAS, Fuego, the Medicina Scholars Program, all the programs we just heard about, they really cover across the whole spectrum. I guess the question is, how can we try to get rid of more of these barriers that we have? For 1 second, I want to talk about, when we think of US grads and IMGs, I wanted to bring this up. I read these two that I thought were fantastic pieces on the value of IMGs, in the sense that in a time where it was needed with COVID, that can be where we can get kind of a pool of applicants that are interested in coming. I think many of you may know Fernando. His quote in the bottom I thought was a very interesting, very human and honest approach to something that we all experienced, or I think we all experienced when we left our countries and decided to come here. And you feel like you're leaving your country and that you could be helpful there, and then you realize when you come here and you're taking care of patients that you can understand much better than one of your colleagues could. You start to see the value again. So wanted to bring that in there. Here's another thing that I wanted to bring up is, so we think about how we can help recruit more Hispanic students, and I thought of this in different categories. So we have early outreach, networking, building bridges, celebrations. Many of the things here we already covered. I hope that there's a few here that are new to you and that you can consider doing. For early outreach, we have all these different programs. I actually added the NHMA College Health Scholars Program. A fantastic idea, along with so many that we heard today. How can we go to those who haven't even started med school, and how can we get them engaged, involved, interested, and then coach them throughout? There's networking for sure, mentoring a student, helping with application reviews. There was a fantastic workshop during this meeting that was helping with the CVs and kind of helping. I think it was geared towards IMGs, but it can work for anyone. And it was like, let's look at your CV. How can we make it better? Looking for opportunities to facilitate rotations. There may be rotations available. You may be able to host someone who needs to do a rotation. So that's another way we can get involved. One that I particularly want to focus on is the next category, the building bridges. And something that I was very surprised when I was a chief resident, and then when I got involved with the residency program at the Cleveland Clinic, the way the process works is really fascinating. Like all the filters that are available for, there's 2,000 applications submitted to a given program. And it's, around 5,000, and it's impossible to review all of them. At least at the two institutions where I was, I think that was the average. That's the number of applications received. So there's a lot of filters that are there. And one thing we can do is we can reach out to the leadership of the programs to ask, what are the filters that we're using? How are we filtering these applications? Because they're fantastic applications that we're never really reviewing. That's what I meant by getting involved, discussing the filters with the program leadership. This can come, I think, in two ways. Some programs do have a percentage of minority applications that they would like to invite. And one thing I can suggest we can all do is reach out to the program leadership and ask, how can we make that percentage match the population, match the percentages in the population? I feel like if it's asked that way, it helps, because then it puts in the program leadership this idea that, well, there are some people within our institution that really want to see that higher, because it's, unfortunately, we're starting at a lower point almost universally, so I think everywhere it will be higher. And then another one that I think could be really useful would be this very last one, celebrating, highlighting great performance from a student, a resident, or a fellow. So for all of us who work in medical education, how many times you see a fantastic job from someone, and do we always communicate that in the same way we would communicate a concern? I've gotten in the habit of sending emails and copying literally everyone I can think of, just celebrating this, and whenever I can, I even write where they're from, and I write how they take care of their Spanish-speaking patients, and I try to specify those things because I think they will never hurt, and I feel like those are effective ways of naturally and organically showing the importance of having these students that are already, these residents in this case, that are already there, stay there, continue there. And then, yeah, make it as visible as we can, sharing with our leadership. So I think those are the main ideas that I wanted to discuss today. The other that I want to add to this is, when I say get involved with the residency leadership, if you work at an institution that has any residency, any specialty, they are looking for people to interview applicants. I bet you, like I promise you, they will never say no. It's one of the things that a program needs the most. Get involved if you can give a little bit of time, get involved, do 1 day of interviewing, do 10 days of interviewing, whatever you can. And if you do, ask them to let you interview those, like in this case, ask them to interview Hispanic, if you can interview the Hispanic candidates. Because just like I recognize Dr. Osorio's name right away, if you are being interviewed by someone that you can relate to, there's a higher chance that that person will want to be where you are. And I feel like it's empowering in a time where there can be a lot of self-doubt as well. So that can be another effective way. And then just thinking about all of this, I think one of the things we could all do is try to collate these ideas. I want to think about them as small acts of advocacy that we can do locally at our institutions. And I think that the ripple effect of all of them together can be pretty large, and we can really try to change our own institutions slowly to better match the need that we all know it's out there. All right, thank you.
Thank you. Okay, so now we're going to have questions and answers from the audience. I want to ask you to please make your questions brief, and if you want to address one person up here, please do so. What we'd like to do is have your questions, again, the focus of your questions should be on how can NHMA collaborate with these types of institutions, and how do you feel, from your experience, you can offer the questions that you know you can help participate. We're looking for participation of NHMA, and so that we can nominate more people to get involved in the types of activities that we can also learn from our esteemed colleagues here. So, and please identify yourself. Yes.
Yeah. Hi, I'm Jorge Moreno. I work at Yale School of Medicine. I'm an assistant professor of medicine there. And I'm hoping to create a Hispanic Center of Excellence at Yale. I have no idea how to do it, so I will be emailing you to help me do that. My question is really, first, once you do become a Hispanic Center of Excellence, how do you continue the funding? Is it automatic? Is it not? Right now, the application is closed from what I saw, so.
So ooh, is this working? Yeah. Sadly, HRSA has very limited funds. I can tell you that most Hispanic Centers of Excellence or Latinx Centers of Excellence are funded through a HRSA grant and originated from a HRSA grant, but that has been cut down. Our center lost its funding in 2017 and is only been funded by the state. So I highly recommend that you get dual funding, that your university make a commitment and say, even if you don't get that HRSA grant or you don't find another source, we will support you in the years of need, because there will be years of need. So this has to be something that you start with the intention of making it permanent, because your community cannot tolerate having something present and then having it disappear. Our institution actually, within 2 months of arriving on the job, I realized, oh, the grant's due in 2 months. Okay. And we spent day and night writing it. We scored a 95 out of 100, which is an incredibly, fundable score, and did not get funded. Wow. I know another institution on the East Coast that scored a 96, did not get funded, right? And so this is when you need your institutional commitment to support the program. So I would start by having the conversations across the institution and making sure that the leadership is committed, or getting them to commitment.
Thank you.
Next question?
Hi. Hello. Hi. My name is Diego Verano, like summer in Spanish. I came from Houston, so I will do like a couple of lines and then a question for all of you. First, I have to present myself like a Western guy. We are sons, just to remember everybody, we are sons of Martin Luther King. We are the sons of people that went to Europe in the Second World War to fight against Nazis, And we are also relatives of Rosario Pichardo, that she died, and she was in the service, a woman in the Kabul bombing, 13 service people there, 5 were Latin people. So just remember that. Now, my line is about this, the euphemisms that we're using here. And here in all these discussions, I'm sorry, I have to do like the king doesn't have clothes, okay? I'm sorry, it's not taking any personal stuff but against you, but there's some couple of things. I am personally IMG. I have to differentiate between IMG and a Latin IMG. It's different. I came from South America. It's different my background to a rich person from India. So, let's start for that, IMG thing is a euphemism. It doesn't exist for doctors that we need here. Second euphemism. DEI, I think that, as Dr. Baca said, I'm not saying this personally with any of you guys, but Dr. Baca said really clear, we're in the US, we have a history of racism, we had a civil war, really bloody civil war. I don't want to see that again here, it's really bad. And the last thing is, I think it's kind of unfair that Harvard has already 30% of applicants like Asian, and these guys are looking for more, so that's kind of disgusting. My question now is, what do you recommend to do in the short term to improve this situation to everybody here? Thank you very much.
Want to start from the one side and work down? Just one comment on how to improve the situation. I know you gave a lot of ideas in your talks, but how would you say that your institution can help?
Yeah, I think that there's certainly a lot. Sometimes things are not great and they're getting better, and I feel like that's what we can strive for. Like the changes that we can locally do, understanding that things are not perfect, but that a lot can be improved. And I feel like individually, I would focus on looking at your institution and really trying to maybe staying with what I was sharing, my idea about advocacy, how it changed. and understanding that there's a lot you can do individually by sharing your thoughts, your ideas with others around you.
I'm going to just say that I don't think that raising the Hispanic people means that we need to put anybody else down. I think that actually caring and loving for all races and ethnicities is what's going to move us forward. And so we need to stop thinking about the pie as being limited and just make more pie.
Yeah. Next.
Completely agree with that, Dr. Vela, thank you. And I would also say that we have opportunities for representation. To Dr. Rios' initial point, why we're here today. I think it's really important for us to think about what are those opportunities where we want our community nominated to be able to attend to the health of the entire population. So it's not enough to say we're going to diversify the workforce to meet a certain quota. That is not at all what we are going for here. What we need to do is we need to improve healthcare for all. And the way we do that is that we need to ensure that everybody is prepared to take care of all patients, and we do need to increase representation as well. So there are a number of opportunities at ACGME. There's going to be an open nomination process for our advisory committee, for example, in diversity, equity, and inclusion. Coming in a few months, we have an upcoming meeting coming up soon, and we have 3-year terms for those committee positions. But there are also others, for example, in your specialty societies. So if you're in a particular field, if you are not familiar or involved with the specialty society that is part of your specialty, that's where test questions are made, right? So there's a committee that creates the licensing exams for your specialty. And if you get on that committee, then you get to write the test questions. And assessment drives education. What we don't assess, we don't teach, because it's not being emphasized. It's not getting recognized as part of the licensing process. So I think getting involved at those tables, I think, is critical for our community. So I think those are some opportunities I would highlight and invite all of you to consider. What are the things I'm passionate about? Is it something in my specialty? Is it a particular issue? And then try to make it better for everyone by joining and having a seat at that table.
Next.
I'm just going to say I want more pie.
Okay, that's good.
I guess one of the things I would, and I agree, I think the pie is a really important thing, but I think we get focused on fighting over the smaller pieces, and not focusing on who gets the biggest piece and why people get the biggest piece. And even, so I think even in the case of IMG versus USMG, somebody created a culture and environment that made it so that one is better than the other versus it being equal. Or versus, so those rankings, especially in assessment. So I think we're seeing some progress in terms of, like, USMLE is an example, pass-fail. That's a much better way of assessing than to try and do this ranking system where people get graded. But that goes on from elementary school in the United States all the way through post-secondary education, where we base everything on a ranking system where we're allowing people to be compared and used as someone is better than this person or worse than that person based on this, and that allows for also inequitable structures in assessment where people get graded either with greater enforcement or under enforcement, depending on who it is and depending on the bias. So I think those are structures that are built into these systems that have created these inequities very deliberately. It's not accidental to give advantage to one group over another, and to create an environment where we can say IMGs are not as good as USMGs is another example, or whatever it may be. Women are not as good as men, or, you know, all these comparisons go on in all these structures that deliberately give advantage to one group, and we see that reproducing itself over and over again. That's why we have 90% of the physician workforce looking the same way. It's not accidental.
Next question. Please identify yourself.
Thank you, Dr. Rios. My name is Riley Pilar. I'm an incoming OBGYN resident and have the pleasure of being able to work with Joaquin Baca. I have kind of a two-part question. So my community is majority migrant farm workers, first-gen students, and even completing high school education due to multiple factors, and the thought of attaining any type of undergraduate education is challenging, let alone the thought of medical education. And when we talk about these pathways, what are ways you see that we can uplift and invest in communities at all levels to be able to help them through these processes that seem unattainable at times? And then additionally, as big organizations like the AMA, NHMA, how can we, with all of this political power and workforce power, be able to support your efforts as well? Thank you.
Who wants to answer? Just
I'm
one
going to talk a
example.
little bit about the equity issues. So one of the things that we have found to be very successful, particularly in the Central Valley, thanks to Dr. Kathy Flores, is making sure that young students and their parents, so very similar to the Academia de Padres, understand the educational structure, first of all, in the United States. And so there is these programs that provide education, not just for the students, but equally to the parents, so that they know that yes, higher education, one, is attainable, two, there's financial aid available, so they don't have to stress out about what it's gonna cost them, and three, that there are programs that will support their student throughout, right? So it's not just about graduating high school and getting into college, but being successful in college and what those programs are. And bringing some of those programs so that the parents can see that they actually exist and that people like them are in these programs and have been successful. So one of our graduates from the APP program is now a medical student at UC Davis who just presented a poster yesterday, and making sure that parents see her and she looks like their students really helps a lot. So that's just one of the many ways that doing something in an area that has a lot of disparity is able to shine.
I'm going to encourage
next.
you from the other end to elevate the lives of migrant farm workers and their contributions to this country. You know, food did not stop coming to our tables during the pandemic. They didn't stop working, and they faced actually greater environmental health hazards with no protection. We need to resource them so that they can live the kind of lives where education is actually a possibility and they're not just surviving.
Thank you. Okay, next question.
Hi, I'm Dave Gordon from the University of Michigan Medical School and Health System, and I also work with our Office of Health, Diversity, Equity, and Inclusion. My question really is, we've talked a lot about the pipeline, and I'm certainly aware of a lot of the leaks along the pipeline and a lot of the barriers and things like that. But how do we advocate for more faculty and maybe even drive home the importance of faculty? Because as I like to mention when I get a chance to talk to students and house officers in particular, faculty are so integral in terms of being decision makers in this whole medical business. They're the ones typically who are sitting on admissions committees, you know, for either medical schools, residency programs, fellowships, NIH grants, HRSA, things like that. And so, but I think people don't realize necessarily the power that faculty have, and we need to diversify our faculty. Now, at the University of Michigan, where I'm a full professor, I like to say very active emeritus professor, you know, we don't have the best record. You know, we have about 5% underrepresented in medicine among our faculty, which is about 3,000 actually in terms of our faculty. But I don't know, any strategies within the NHMA and also ACGME to help promote people to consider issues of faculty and dealing with barriers to becoming faculty?
Let me just answer real fast, because you did ask about NHMA, and as you think about your answers, please comment on how NHMA can help with what you're thinking needs to be done. The NHMA does have a nomination process every 2 weeks to our members. We also have a job board, and we also have announcements of specific faculty positions in different places. We need to make that more visible. How are we going to do that? By having medical schools join NHMA as institutional organizations. We want to serve the medical schools, but you know, we're not inside all the medical schools like the medical students are or these speakers are. We're the alumni, we're IMGs, we have a resource, and it's our human capital, it's our members. So the more members we can have, we can serve the members of the medical schools who join us. And that's what we need to do. We're focused on chapters. We need to start a chapter in Michigan. We had some doctors here. We had one of our sponsors here from Michigan. But we need to focus on geographic areas and start with the piloting of the networking and the resources in these major areas of the country, like Chicago, where there's 7 medical schools, Houston, lots of medical schools, Los Angeles, New York City. But we need to go to places, other places too. But we need the medical schools and the hospitals, the community health centers, to all see the value of our Latino members and doctors and public health people, dentists, nurses, everybody else. So I think that's part of what we can do for the future, for increasing faculty in the schools that want to work with us. That's what we're going to have to do, is focus, because we can't do every place. Mm-hmm. Okay, so what's a nugget of wisdom on how you increase faculty? Maybe just one example so we can get the rest of the questions in.
So academia is a very funny system, right? And being an incredible clinician does not make you an academic faculty member or even a celebrated faculty member. Being an incredible leader or mentor also does not make you a celebrated faculty member. What does is bringing home research, grants, and publishing. And we fail our students when we don't tell them what academia is actually about. And if they want to be academicians, the best way is to engage them in research as pre-medical students and medical students, because there's a wonderful study demonstrating that those who end up publishing or even conducting significant research during that time period will stay in academia. So that's my nugget, is open up, unveil what academia is actually about and who gets celebrated and who gets to become a dean or a chair, and point them in the right direction.
Right, great, thank you. Next question? And we'll stay here another 15 minutes. So
Okay, I'll make it brief.
Yes.
Hi, my name is Pablo Puente. I'm very happy to be starting medical school in August at the University of Illinois. And at this, thank you. At this early stage of my career, there are some issues that I'm really passionate about addressing, and eradicating health disparities has become one of my passions. And when I see cancer health disparities and screening for Hispanic patients, there is no reason why we have to see patients not being able to get an MRI for months and then making their situation worse just because they're uninsured or just because of a lack of access to healthcare that's around them. And that's something that hasn't been alluded to. You could give a Hispanic physician the resources. I navigated the system all by myself, and I want to make sure I give back to my fellow pre-med students and help them become to where I was able to get success. But you can train all these physicians, but you still see inequities in our system in which a lot of patients, Hispanic patients, don't have access. I don't want to see someone's abuela not being able to be screened for a colonoscopy, and then that turns into a probably even worse outcome. So I want to hear from the panel just how, as medical students, we can become advocates and just address this issue.
I'll be happy to answer a few ideas. So yesterday there was a fantastic talk on vaccination and how what started as a challenge where the Hispanic population was way under, it ended up becoming, after a few interventions, where they were actually the highest group. I think that highlights the importance of understanding our patients. First of all, of having more of us be there where the decisions are made, being able to drive it. As a student, I would say virtually every school will have some sort of volunteering opportunities. For example, during COVID, there were many student-led outreaches where we had students, and particularly students who spoke Spanish, reaching out to patients, to talk to them on the phone, to ask them what questions they have. So I would encourage you, and first of all, congrats on starting med school. Once that you do, I would encourage you to check with your school what are opportunities at the school level, what is already going on, and what are outreach, either electives or opportunities you can involve in, and you possibly can lead some of them as well.
And just to add one more thing too, I think students have driven curriculum. They still do. Medical Spanish is the perfect example of that, because almost everywhere in the country where you ask, how did medical Spanish get started, even in those places where it is now faculty-led, which thankfully that's increasing, it has always been driven by students. The Latino Medical Student Association has been key, and individual students have been key. I myself started teaching medical Spanish as a medical student myself because there was nobody else doing it. So we need to stop looking at these things as hobbies and extracurriculars and looking at them as professional skills. That is the transition that we need to make, and in fact, using the skills that we have to publish so that we can later get promoted and get into that habit, right, of taking this work to a scholarly level. And actually, there's a paper by 2 medical students about medical Spanish professionalization that just came out in the Journal of the NHMA. That was the inaugural issue. So that is an opportunity for all of you too as well, thinking about how do I get my scholarship in there, how do I get promoted? I think that's a key one for you.
And let me just say, for advocacy purposes in this country, the biggest insurance company in the country is called Medicaid. If we expand Medicaid in the states like Texas and Florida, we will do more for the Latino community in this country than anything else we can advocate for. The other, it's Medicaid expansion. The other thing is every state has Medicaid options. So California, Illinois, other states that have lots of Latinos have made an option to cover the undocumented through Medicaid, through the state part of Medicaid. This Medicaid is a federal program and a state program, and when the states put money into Medicaid, they can also put money into medical education from Medicaid, but the idea is that there are advocacy at the state level that NHMA does now with California, New York, Texas, and Florida. We need to do more targeted state advocacy, maybe all one activity that might be Medicaid connection to medical education, or Medicaid connection to healthcare for all, lowering the uninsured rates of the Latinos in this country. But that's what we can do together with the Latino legislators in your states, and we can help with that. Okay, next.
Muchas gracias.
Quickly, Dr. Rios, just
Yes.
to, AMA may be helpful with NMHA because
Let's
of
do
the
that.
state medical associations and our
Oh,
relationship.
okay. We need to leverage and work together to help. We don't want to duplicate efforts. And by the way, we're part of the amicus brief against the Harvard, what is it? The Students for Affirmative Action or whatever they're calling themselves. The Asian and white people, students, we're against them and for the Harvard and North Carolina side, with the AMA and the AAMC to keep race-based admissions. Next, yes.
Hello, everyone. My name is Anna. Thank you so much for such an insightful presentation, everybody. My question is mostly, I think, towards Dr. Ortega and Dr. Yudelevich. My last name is Pancheshnikov, so I feel you. I'm in grade 27, as I like to call it, or the end of my gynecologic surgical fellowship. And thank you. I am more and more in like different committees, you know, for applicants, like more for residency and fellowship, even for, you know, my new job coming up. And we interview a lot of amazing Latina and Latino and immigrant applicants. So these are people who are extremely accomplished in research and achievements, many times thanks to your type of programs that you just described. Yet, then they interview, and in the post-interview kind of committee conversations, I hear things from the committee members like, oh, she wasn't able to describe her research or achievements with much passion, or with my, I couldn't understand, what her research was about. And it's so, so frustrating to me. So Dr. Yudelevich, maybe you can discuss about how we as physicians and advocates can teach students, residents, fellows to participate in this American peacocking system of bragging and talking about your achievements, and how can NHMA and ACGME demand from programs to understand the cultural differences in conversation and describing your achievements?
Thank you.
Thank you for the great question and for the pronunciation of the last name. Very impressive. You have a very valid point there. I think that there's always those. I think it's a combination of a bias that may come. I distinctly remember one of those ranking meetings where someone came and asked me if I knew the school where they were from, and I was like, yeah. And they're like, do you think they maybe bought their diploma? I was shocked. I was like, yeah. Anyways, won't go there. So I think there are biases that sometimes come out to light, sometimes they don't. On the other hand, the applications, and this is something that we actually discussed last year with the IMG group here, it is sometimes very interesting because you see applications from countries in Latin America that on volunteering activities and leadership, there's pretty much nothing. When you're interviewing them, they're telling you of all these things they do. You're like, where are they in your CV? So I think there's a lot of opportunity for education around it. Fortunately, there's an IMG council being formed through NHMA, and I'm hopeful that that can be something we try to tackle together. Like, how do we reach out to those who are applying? And I think that's not only for IMGs. I feel like there's culturally a little, I think it's humility in a way that comes with not always recognizing what we do as something valuable that we should put in our CV. But then guess what? Everyone else is doing it. So by comparison, sometimes our applications can unfairly look like of lesser caliber. But that's not because the achievement is not there. So I think there's work to be done.
And I'll just put a plug in for NHMA's nomination process. At all levels, students, residents, faculty, senior faculty, or those that are in private practice, we get nominations all the time. And what it does for you is advance your career if you can match something that, if you want to do research, we can put you in research committees or NIH committees. We can help with finding funding opportunities or how to look for funding opportunities. We can't have everything, but the nomination process is really an open door again to advancing your careers. And that's something that we all need to think about, using NHMA, especially for those types of committees that can get you to the table that you wouldn't have gotten otherwise through your own institutions, because they, let's face it, it's an old boys network, it's legacy. Most of the admissions process in this country is the professor's sons and daughters first. That's why the recruitment has to change. And I'll just say one other thing. We're in a 5-year grant that we just started this year from CDC. Levon is here, our project officer, for the National Hispanic Health Foundation to find new strategies on how to recruit a diverse workforce for public health, not just for CDC, but for the state and the county. And the lessons learned can translate to all of our health professionals. We're working with HBCUs, tribal colleges, and Hispanic serving institutions. And if anybody here would like to help us, we're having listening sessions. We're opening up the door to more ideas, especially the younger generation, on how we can recruit you to the future of public health in this country. And we're gonna focus on MD, MPH. We're gonna focus on doctors and others that are in public health that wanna work with the fellowships of CDC. We wanna focus on how you come from counties that are rural farm workers, so that we find more recruitment attractiveness for those people that are, like our Central Valley chapter over there, Becky. I think that's the way we're gonna recruit for the future, for the pandemics of the future. But anyway, that's another item. And quick questions, Sorry.
Let me
Oh,
just
sorry.
add to the answer to this question. One is we need to teach the students and faculty who are Latino and from other underrepresented groups to use, I think, a gratitude framework to think about their achievements in a way that I think it helps them to think about, to be okay with what feels like bragging. I am grateful that I had this opportunity and I'm going to put it here. And I'm doing this not only for me, but for the next person that comes behind me. Because if I don't do this and if I don't shine, then nobody else can. And so I think looking at it from that perspective, I think is critical. The second piece is that we need to teach our faculty and people who are at those positions of power making decisions as to what are the things that we value. So I think we need to go back to the drawing board. What does our institution value? And then how do we look for that in applications? Because it may not be the typical things we've been looking for all these years. We may need to change that. How do we do that? Well, one of the ways is you may want to consider joining our DEI Officers Forum at ACGME, which is a session that we hold once a month on the second Wednesday at 4 p.m. Central over Zoom. And we do professional development. So we know that people who end up in these DEI officer leadership positions or who are thinking about it or being offered the positions, or maybe they used to have it and they don't anymore, or whatever it is, they don't get any training usually as to how to deal with the issues that are going to come their way. So we provide that, and we provide also a safe space and a community to be able to share what concerns and vent and whatever else you need to do in order to not burn out and to be, you know, who you are in your role. So.
Quick questions.
Of course. My name is Sonia Oyola. I'm the Director of Medical Student Education at the University of Chicago. I've been a family medicine doctor since 1997. I'm an immigrant from Colombia. And I'm here because of Jorge Girotti and the Hispanic Center of Excellence at the University of Illinois. It was hard to hear that the Hispanic Centers of Excellence are now less now than ever, and it seems like that might be a direct correlation to why we have less, or the numbers have not moved at all. And I was wondering about diversifying funding sources. I think about sponsorship instead of mentorship, and mentorship together. As a nonprofiteer, someone who runs a nonprofit in Chicago, a lot of how we support and elevate a community is investing in the individuals in that community. So, and sponsoring those specific individuals. So I'm thinking about the 30 students that don't get supported through the 3 years. Like, how does the NHMA create a sponsorship program potentially for those 30 individuals? We have lots of members, we have lots of capital. I would sponsor one of those students right now.
So we have a foundation, the National Hispanic Health Foundation. That website is nhmafoundation.org. We have a special donation or contribution. It's tax deductible because that organization is 501c3. NHMA is not a 501c3.
Okay.
NHMA was developed as a trade association to represent the interests of doctors and to have education of the doctors. But our foundation is the place to donate.
Okay.
And you can specify the donation. Right now, our biggest donors are for our scholarship program. In a sense, that is our sponsorship program. We have up to 40 scholarships a year, $20,000 scholarships. Some are $2,000 scholarships. It depends on the sponsors that we can get. But we also have an endowment that we're creating. We'd like everybody here to know that that endowment is for the purpose of that scholarship. That we're not at the endowment levels yet. Once you hit an endowment, if you get $1 million in an endowment, you can only spend 5% on the scholarship. So right now it's an investment account. And what we're asking is for donations to the investment account, and it's up to the board of directors of how much would be spent on, let's say, student sponsorship. And again, I want to stress, and you guys could chime in on how you develop your focus and redirecting funding. We can't fund every medical school students. We have to figure out a way to prioritize the schools that have the value, that want to join the NHMA organization or want to join the scholarship and donate to the scholarship. We need to figure out how to help the students that are that are in these places where we need to help. We need to figure out that. So any ideas you have, let us know.
Social
But-
media, I would say social media would be one, storytelling. I mean, any one of us that have benefited with, and lots of gratitude, I'm so grateful to the Hispanic Center of Excellence, because I wouldn't be here
Yeah.
without it. So like highlighting those of us that have benefited from those programs and sharing those stories, I think publicly, more publicly, could warrant, instead of just internal sponsorship or internal support from the members,
Yeah.
public support as well. But I think that would be something to consider too.
Yeah, any other ideas on how we can have more support from within our own communities?
I would throw out, so I'm going to keep pushing that there needs to be larger structural changes. Like we're making up for the deficits of the larger systems and structures that have been unfunded for many years. So
Yeah.
from that perspective, we need to all advocate for basic systems to be improved, like education, housing.
Of course.
You know, those are the things that I think if we need to raise awareness around that and make sure that as physicians, you're also advocating for those larger structural changes as we're looking for,
Yeah.
at the same time addressing the immediate needs that have to happen.
Okay, let me just go to the next question real fast.
Thank
And the last two.
Sam Marcy, past chair of NHMA. I don't know if I have a question, but more of a comment. If we think we have it bad now, you have to think of what it was like before even NHMA existed. That was even a worse situation. So I think that it can't be about me, it has to be about us. It has to be about getting involved, and you don't always have to have that top position. But if we get to the table, we can help make these choices. And so we partner with each other. AMA and NHMA have partnered. I'm on the governing council for MAS. And so we've seen that light, that we can't do it in an isolated situation. We have to work together to be able to create this environment that we need to create for the future. It's not going to happen overnight. Even when NHMA started, we didn't get to where we're at today overnight. That had to take a lot of work and a lot of effort. So I guess what I'm trying to say is I'm trying to encourage people to get involved.
Yeah.
You don't have to, again, go to the top seat at the table, but somehow locally get involved, and before you know it, you'll be making a difference. I'm not talking to you guys, because you guys have already been there and done that. But if we all get involved, then we can make a difference. I remember, as a side issue, I had many students come by my office, and I would teach them a little bit of Spanish. None of them spoke Spanish. I had no problem with any students, but I had this one jerk. I'm sorry, did I say that? I had this one guy who, I told him, tell the patient, respire profundo con la boca abierta. No big deal. If I have to repeat it 10 times, that's okay. No response. Repeat it again, no response. And you know what he told me? He told me that because he was going to be a surgeon, he didn't have to learn how to speak that way. Now, I could have taken my pen and used that as a weapon, you know, not to throw it at him, but I could have used it to fail him. I chose not to. I didn't give him a really good evaluation. But then it was interesting that the medical school came back to me and said, you know, you did the right thing because you would have been sued. Now, I think we need to look like our communities, but I don't speak Russian but I can still be someone that can be sensitive to their needs and be culturally relevant.
Yeah.
So, thank you.
Okay. Last question.
My name is Dr. Mercedes Martinez. I am a bilingual, bicultural, board-certified child, adolescent, and adult psychiatrist, and as you know, it's 1%. I was dismissed by the state of Illinois through no fault of my own with false allegations, one in particular pretext of not having an active license. Please, this breached the Medical Practice Act, Section 21. Why? Because I went on a limb. There are other doctors going out on that limb to demand linguistic equity and mental health treatment equity in the name of, of the above, our creator. So I would ask, soy Joaquin, Dr. Joaquin Baca, and Elena Rios to have a course that provides people like me the laws that can protect us, because I went through everything not knowing but learning about it, and now the Civil Service Commission, 4 commissioners, 1 chairman, and 1 administrative law judge approved my reinstatement. The state of Illinois is taking them to court and me. Help.
You want to comment on?
By the way, I'll be available in the Council of
specialties.
Pediatrics for those students that are interested in going into psychiatry.
I'd love to hear more, and so we'll make contact after. But I think one of the things I heard in this is there is no standardized training for, as an example, interpreters. So interpreter training is non-standardized, and there's no degree path. There's no way of acquiring that certification that is standardized. There are places that offer interpreter trainings, and they certify themselves what they say is acceptable, but it's not a national standard. So there's all these complications around that because of the way that the policies have been created. So I think that's one aspect that we can really explore, especially from the policy, the advocacy side of the American. I have to look at our own policy at AMA, but I'd love to hear more. But
Yeah, let me just say from the NHMA perspective, I know doctors that have lost their licenses in California. Surgeons, because somebody died at the table, the family sued. Negligence, but I'm just going to say it's a gray. We have lawyers in the room, but let me just say that there are discriminatory reasons that are getting up to the medical boards in California for Latinos that are speaking out about the importance of diversity, and people don't want to hear it. The chairman of different departments are writing faculty up. Now, they didn't lose the license because they would have gotten sued too, the institution. Other doctors I know that lost their licenses because they were giving too many opioids and pain management, and with the opioid crisis we have, the attorney generals of this country decided that let's just look at the prescriptions and how many prescriptions are given by certain doctors. Let's have a cutoff and stop all their licenses.
I just want to qualify, I did not lose my license.
No,
I
I'm
renewed it
not
in
talking
2
about
weeks.
losing a license. I mean, I'm not talking about you. I'm talking about the issue of helping doctors that are getting written up or about to lose a license or may have lost a license, and how can it get reinstated? When you said reinstated, that's why I thought you lost the license. But anyway, I do think it's an issue for the next year's conference that we talk about how to avoid, just like we want to avoid burnout, we want to avoid losing your license, because we need every single one of you. So with that, I want to.
Can I just clarify one quick point around
Yes.
the certification issue? So I think there's 2 things that we're actually talking about here. One is certification of language concordant physicians to provide direct care. Currently, we do not have a standardized system for that, and we need that. We're working on it. We do have a standardized system for interpreter certification. It is variably used at different hospitals, but there are 2 nationally accredited organizations that do certify medical interpreters. What there is a major confusion as to what an interpreter is as opposed to what a bilingual doctor is, which is completely different skill sets that need to be certified through different avenues. So we can, of course, talk about that hopefully
I'd like
next
to
year.
clarify
I
that
think
this
that
is not
should be
about
another
interpreters.
conference.
This is simply bilingual, bicultural staff, nurses, social workers. They didn't have anyone, or mental health techs. And a social worker and I both advocated, were both dismissed. Why? Because we stood up for the 80% non-English speaking Spanish patients in our unit that we were trying to serve.
Well, we support everybody that stands up for our communities, and I want to, again, get back to just saying thank you very much for giving us a lot of ideas on how NHMA can be more involved with medical education, and the idea that medical education is at all levels and that we need to continue to, for next year. Okay. So can you put that in your evaluations? Everybody look at the QR code and give us ideas from this session on how we can improve and increase our speakers and content. Thank you all very much.